I think somebody's mic is on, so that can be switched off. Sorry, everybody.
Sorry, everybody. Yeah, someone named Vidya, please. Would you mind, Dr.
Yeah,
Vidya, please? Please mute your microphone, everyone, please. I appreciate, only Dr. Dave, whose microphone may be on, please. Yeah. All others, kindly switch off your microphone. Thank you so much. Yeah.
okay. Sorry, we have wasted 10 minutes in this. But anyway, I will pick it up. Now, welcome everybody. And my topic today, given by GCI, is genetic counseling in prenatal genomic diagnosis. Okay. So the thing is, when it is there as a genomic, everybody wonders what it is. And I thought, what is it? When was the origin of this word? When I searched for it, I saw here is that Tom Roderick. He is the one who coined this term genomics in way back in 1986, and that means it is an area within genetics that concerns with sequencing analysis of an organism. So mainly it is the study of all genes at the DNA, messenger RNA, and proteomic level, as well as at the cellular or tissue level. And we know everybody the discovery of Watson and Crick, discovery of the DNA molecule by them as a young scientist. And if you see the photograph, I really love this when they had come to Bombay TIFR. And you can see the picture taken there around 63 or something. So anyway, the 2003 was the completion of the Human Genome Project. But as a discovery of it, or the completion of that project, a lot of the discoveries were done, which were correlating with the diseases, which is the gene related with the gene defect, and which is the disease related with exact that gene defect mapping, where on which chromosome, etc. So we were all clear that it is a blueprint of unit of human karyotype 46 chromosome. It was clear in that. For example, if you see over here, it is, very well that on which chromosome the gene for the sickle cell will be there, chromosome 11. So everything was mapped, and we have now very ready human genome map. And then the technology went on. There were more and more advances because of the bioinformatics technology, because of the advances in genetic engineering, etc. And more from the karyotype which was discovered. From there are more genomic methods were also developed for screening and diagnosis of genetic disorders. So as you can see over here, there were fish developed which are for the specific probes or specific syndromes, and you can see in the your prophase, no need of the culturing, you can see in the cells. Or there are color spectral karyotyping came, the chromosomes map, and even structural defect, the translocation can be seen. And of course the sequencing came, and that was the discovery all of us very well know after the PCR. So, in advances in molecular cytogenetics took place, genomic technology started. Not only that, even the single fetal okay, so genome analysis of fetal cells become very crucial and important, so as to find out the any defective gene mutation or any disease that is going to occur or not in that baby. And as we know from 83, with the automated DNA amplification, the PCR reaction was very important, and that really made the breakthrough in the genetic technology. So 80s we saw fish, 90s we saw the hybridization, cytogenetic microarray came, and the 2000, the last decade is in India, maybe this last decade more, or the last 5 years more, with so many companies entering in India, we saw this the growth of the clean exome sequencing, whole exome, but we are still having the problems, challenges, which we'll see through my talk and through my some of the case presentation. So the talk will have some of the case presentation to show what is the genetic counseling and in prenatal genomic diagnosis using these technologies. So we moved forward from the karyotype, which gives also 21 trisomy. So aneuploidies, the larger structural defects, they could be seen. But then again, there was a high resolution also, cytogenetic microarray came. And those things, there was a shift from the non-microscopic towards from microscopic visual to non-microscopic gene database bioinformatic tool, because you can see here the changes even more than 1 MB at the very, very high resolutions, as small as 10 KB also. And you can see the chromosome, the banding, the precise location of the gene. So that was also again, and in the case of intellectual disability, it really made a very, very important, it was a milestone in the diagnosis of it. Not only that, the ACMG guidelines also came and started. Now it is that microarray is the important. Nevertheless, karyotype is a gold standard. So then the next generation sequencing came. We saw here that more than 7,000 genes or the more coverage. It is a powerful platform that has enabled the sequencing of thousands and millions of DNA molecules. And now with that, since there are thousands and thousands, to make it cost effective, the panels came. So you can have, in case the clinician, and it is very important to understand that the clinician also has to understand the biology of the patient. So in case the clinician understands the biology of the patient, he can also
Yeah, yeah.
Yeah, ma'am. I think we lost you. We lost your connection. Others, would you all mind, muting your microphone? Shalini, you can also mute your microphone, mute others' microphone, if someone is not able to mute. Okay. Yeah. Thank you so much for standing by, dear all. I think um, Krusha has had some connection problems. She'll be back. Thank you so much.
Mhm.
Yeah, then Lakshmi, would you mind calling ma'am if she's posing any problems, please? Yeah. Thank you so much. Yeah.
Yeah, sure, sure, I'll do that.
Yeah, others in the meantime, please allow us to tell you about what GCCI is all about. GCCI is Genesis Clinicians Consortium of India, which we incepted 3 years ago. It is a kind of a platform, taken up by NEA's organization and as well as Bioclues. We aim to bridge the gap between scientists and clinicians. That's because scientists, may not really understand the clinical phenotypes, and vice versa. The clinical clinicians, may not really understand the genetics behind the disease phenotypes. So we wanted to, come forward and join together in making this Genesis Clinician Consortium of India, you know, a grandeur. So far, we are just, in the realm of, making it, to the next level. We have had, wonderful speakers over the last 3 years. Albeit the fact that, we have had some breaks in between. We couldn't organize webinar over the last 3-4 months. But this webinar is again, bouncing back, to the podium where, Dr. Usha Dave is giving this wonderful talk. We have three chairpersons in the form of Sunil Pulipalli, who is a senior scientist at Maulana Azad Medical College, and we have Nayaz, who has had, years of experience working at various institutes as an industry as an industrial expert and as well as a principal scientist, working for various institutes. And we have Dhanlakshmi Shetty, who is a senior scientist and genetic counselor at ACTREC in Mumbai. Okay, so these are the three persons, and Nayaz and I, founded this GCCI. Okay, that was how, we incepted it 3 years ago. Thank you so much. Okay, thank you so much, then Lakshman. In the meantime, you're all, welcome to join our GCCI. If anyone is interested, you can simply email gcci@bioclues.org. Okay, that's how, you can reach us. Thank you so much. Yeah, please,
Yes,
ma'am.
ma'am. Thank you
Please
for
again.
joining, ma'am.
Yes, ma'am. Thank you for.
You're muted, ma'am.
Okay.
Kindly share, and we'll tell you till when your slides were,
Yeah.
visible to us.
Okay. I'm doing. It's not getting shared. Why?
Ma'am, please take help.
Now, see, now it has come.
No, ma'am.
Now,
Um,
I don't know what's
no.
happening.
Um,
I'm doing the sharing. Okay, share.
okay.
Yes, yes.
Fine.
It's
Fine. Mm.
yeah. Now you have to click your presentation, ma'am. You have
Now,
to go to your present.
Yes.
Yes,
Yeah.
yes.
Fine.
Now you can open the full window. Yeah, your full screen.
okay,
Yeah.
now.
I'll tell you. Yeah, ma'am. You go ahead. And I think we have skipped all of this. You can. No, we have not seen all of this. You can go back, ma'am. Back to your slides.
This is okay.
Yeah, yes, yeah. We have seen this. The next one
Okay.
as well.
Okay. So microarray
Yeah,
is done and
yeah.
next generation
Yes,
is
yes.
done. Okay. Yeah.
Next generation, probably you can tell, ma'am, because you were
Yeah.
not there. Yeah.
Okay, fine.
Thank you.
So no, just I was telling, sorry about this technical problems. I do not know why it happened and occur. Anyway, so maybe the light or the network issue may be there. I do not know. Anyway, with next generation, now we are able to do quite a number of disorder which are metabolic or
Metabolic or
hemoglobinopathies or sometimes epilepsy where
hemoglobinopathies or sometimes epilepsy.
there is echo here. Can you see?
There is echo here. Can you see?
Oh, can you hear me? No, now?
Oh, can you hear me? No, now?
Yes, yes, ma'am. Please continue.
Okay. So,
Yes, yes, ma'am. Please continue.
yeah. So now the thing is, why do you need the prenatal genomic diagnosis? Because there is a burden of genetic the disorders in India. When its population more than 1.3 now billion, you can imagine what is the burden in India. Okay, because already it is very well known that 30% of pediatric population, 10% of the adult, even 50% of morbidity and pediatric mortality is due to the genetic conditions. And even they affect the 3 to 6% of population. And infant deaths are only almost 20 to 30% are due to genetic condition. This has been very well now known about it. And so if we have to do prevention, how would you do the prevention? By is by early detection, newborn screening, or you do prenatal diagnosis in the family or the pregnant women to stop the recurrence again in that family. That's the only way you can prevent it. Okay. So now, sorry. So if we
Yeah.
see the genetic counseling, if we do it, the genetic counseling, what is a genetic counseling? It's not a test, it is a communication process, and we know it very well that you have to have a skill also and the empathy along with it when you are there as a genetic counselor. So let's see what is the Harper, who is the father of genetic counselor, we say, and his definition is that it is a communication process by which patients or relatives at risk of disorder which are hereditary or advice of the consequences, how it is developing or transmitting it, inheritance pattern, and how to prevent it, the ways and means of preventing. So the primary goals of genetic counseling is the diagnostic clinical aspects, and the counselor does genetic evaluation by which the documentation of family and pedigree information is taken, recognition of inheritance patterns, and the risk assessment is done by the genetic counselor who has a communication skills and empathy along while doing the genetic counseling. And also counselor provides the possible other options and further measures and helps in deciding the decision. So who is the genetic counselor? We say now the people are, you will see that there are many genetic counselor courses are there, certified courses are there, degrees and diplomas, etc. But the genetic counselor is the one who has a knowledge about genetic disorders. He has to be a qualified person who knows the genetic science about the disorders, about the management of genetic disorder, the number of tests which are used, what are the different types of tests which are used, methods for screening and diagnosis, medical care, and also the proper finally what you do is the communication skill your is also required. So through the case scenarios which I'll be presenting in the next half of the talk is that through which you will see which are the challenges or which are the issues or what is the genetic counselor does during the prenatal genomic testing or the diagnosis. Okay, so the main goal objective, though we know about it, that it is a child to prevent the childhood disability, genetic disorder, recurrence risk. So he has to know how many types of disorders are there. Is it a single gene? It is a chromosomal disorder, or is it a multifactorial, or the clinician has suspected the mitochondrial disorder? What is it? So that is through genetic evaluation and testing. So it's a pre-test counseling becomes very, very important because then only you will evaluate out through the investigation whether it is a genetic cause or the non-genetic cause. Okay, based on, so that knowledge becomes very important. So pre-test genetic counseling is why is it important now is in the prenatal genomic diagnosis because or the DNA diagnosis is a newer one, is a newer technologies. It's not that we used to do the chromosomal abnormality in the first trimester, and the first trimester losses. Now the technology has developed, and then you have to offer the proper guidance to the couple or the patient. So chromosomal cause, we know that pregnancy losses almost 40 to 50% are due to chromosomal aberrations. But even when fetal tissue or POC which does not contain the viable cells, now with the technology you can use a DNA diagnosis can be done. Okay. Then another thing is, when do you need the genetic counseling? When there is abnormality detected on ultrasound of the fetal anomalies and conventional karyotype chromosome has come normal, and then you are going further. Okay. Then there is a genetic etiology where there may be child, infant, adult, whoever is there with disability, mental retardation, physical abnormalities, or any of the congenital anomalies, birth defects which they want to prevent. So such an index case or the family will be coming for the pre-test counseling. And of course, above that, then you will give them about the cytogenetic microarray, which are still the smaller submicroscopic aberration, microdeletion, duplication, and again now this next generation sequencing for single gene disorders or specific mutational testing can be done even on the amniotic fluid, etc., if the index case is decided. So what is the prerequisite? Just remember, for any prenatal genomic testing, the prerequisite for the index case diagnosis is very, very important. But is it always possible? I do not know. But still, when we come and we face across different situations, which through some cases I will show you how you have to tackle and do the genetic counseling. So first is when you have a very apparent Down syndrome or a familial two boys, mental retardation, skeletal dysplasia, autism also is there. Okay. Or there are could be the autistic features, congenital anomalies, CP, etc. Very obvious, and you suspect something like that. There could be birth defects in the family history, three generation. If you see over here, you can see three generation people, or there is a couple coming, two SIBs affected, or there is a very pronounced, you can see as a dysmorphic Down syndrome child, organ megaly also. Then you can suspect certain group of condition where these are there, ambiguous genitalia. So you will think about that. So during counseling, this becomes very important. So now, which prenatal samples you will be doing it for which genomic test? It's also again important. Based on this clinical history data, clinical, you will be finding out whether the ultrasonography anomaly is there, known family history is there. You did the index diagnosis. Then based on that, you are trying to find out the abnormal genomic marker, right? So there are prenatal procedures which can give you the chorion villi, or you can do fetoscopy, or you can do amniocentesis for getting the sample which is very close to the fetus as such, or the fetal representation to find out the what is the abnormality, because you can use that tissue as the DNA tissue of the fetus. Okay. But again, the fetal sampling will differ in various conditions. Now you know well established chromosomal aneuploidy was there. It is congenital defect is there. This which is detected on ultrasonography. So that is fine. So you have you can just do whichever conditions you know about it and specific. There are known genetic syndrome, but sometimes it is only on the fetal NIPS you may go. Now after maternal screening, there may be high risk, and then after the high risk and NIPS positive, you may have to go for the genomic testing prenatal. Okay. Or it is a high risk pregnancy. What is the abnormality on ultrasonography or advanced maternal age, etc. Okay. Then you will be going for fetal DNA diagnostic test as a microarray or clean or whole exome, or based on that also the panels you can choose. So if it is epilepsy family, you have detected something as epilepsy genes, in that case you can go straight away for the specific mutation also. So there are challenges in choosing prenatal or fetal genomic test as such, because at times maybe the family is there and the affected individual or family have lived long ago, diagnostic tests were not there, you do not have any index case diagnosis, or sometimes you will see some of the cases where they have come very late in the pregnancy. It's not possible for you to do the acute because the index case is not diagnosed, or inadequate infrastructure, cost factor was there, At times it is possible that phenotype genotype correlation is not possible due to lack of markers, and sometimes the interaction between the clinician and lab scientist, which we are currently facing in India, is lacking. The clinicians are always, they are not giving the full
Yes.
information. You have to go back, get it back, and at times you have to also make them aware, educate, and think. So this consortium which is there becomes very, very important, and at times there may not be a diagnosis on how you will tackle. Nevertheless, there are regulatory guidelines are there. Now there is the microarrays increases the diagnostic yield. So some of the people have started also in the amniotic fluid straight away the microarray test rather than the karyotype test also. But it depends upon which case is there. It is from individual to individual. It is not that always it is informative, and NGS has to be done at times, and both are the supportive to each other. Okay. So let's see some case scenarios which are very important, I think, for the counseling in prenatal genomic this diagnosis. Uh, as I told you earlier, also why, when, and how you do it, which we explained, that accurate genetic diagnosis has to be done. Parents carrier testing also is sometimes required, because is it a de novo? You are calculating the risk. So something which has happened is a genetic, is it a de novo or is it inherited from parents? So that time parental carrier testing has to be done. And that time the time goes, or sometimes we will see some of the cases the couple also come very late. Okay. So fetal sample, which fetal sample has to be used, that is also very important. And you should have the knowledge about all these laboratory genomic testing during pre and post test counseling. So here was a case, the couple came, the one boy is normal, and if you see this is a girl, and those who are there in the field of genetic can do the spot diagnosis as Cornelia de Lange syndrome, because of the very typical characteristic, the feature facial, very large bushy eyebrow, join, a small low set ear, a thin philtrum, etc., crowding of features. So we know it that it is the Cornelia de Lange. Now that time you have to tell karyotype will come normal as such, which is no point. And in case you go and do specific, because you know it that it is that, and NIPBL gene is there. And at that time when you explain the people, like explain the couple there, that yes, this is a specific thing, what is the management has to be done, why your baby is mentally retarded, all this counseling, and the future pregnancy in amniotic fluid, you can precisely do this imitation. So then it is not very expensive. You have chosen here, you don't have to go for microarray, or you don't have to go for the chromosomal whole exome. You can make it cost effective. Okay. Now, single gene disorder. Suppose it's how do you will tackle the single gene? Of course, there will be certain things which are enzyme deficiency. Here is the example. Why I give this example is the couple is so nice. They have already one nice boy. Still, they have another as a Canavan disease, which is because of the enzyme deficiency and acetyl aspartoacylate. We have a biomarker, we can diagnose it precisely, and we also found that it is a missense mutation in ASPA gene. Okay. Now the patient is a homozygous, we found parents are carriers, everything was explained, but still after few years they come back. Okay. Now that time it was very, very important for us to find out that whether that was the time when we did a parents, we found that they are heterozygous, it is not the de novo mutation, what is the recurrence risk, 25%, etc. And then we did it in the amniotic fluid of that next pregnancy, and saw that it is normal, and continued the pregnancy. Okay. Another here, it is sometimes you will not have the babies with you. Okay. There are already neonatal death. But this was a case of citrullinemia where the last second baby was there. We said you take the DNA, because we knew it that whatever with the clinical features as such, it was urea cycle disorder. We quickly perform on it. And then we did a exome sequencing, because then there was no time of further biochemical test to confirm. And there was important this in this case, because they have to do the next pregnancy. So when we found out that it is a severe neonatal citrullinemia case, because of which the deaths are occurring. Now, in this case, your counseling becomes very important, that you have to how convince them to do the exome sequencing, that this is the mutation which we found, and how you can do it in your next pregnancy. So that communication becomes very important. Another example here is that the couple comes with consanguineous marriage. They already have the other girl. This is the second girl, but hepatosplenomegaly. Now you should know that hepatosplenomegaly, you see it in a certain group of disorders. Based on clinical features, etc., we saw this cardiomyopathy, motor developmental delay, splenomegaly, that glycogen storage, it could be. So we did a panel of it, and then we found out that it is a glycogen storage disease, GSD1A as such. And then we found it G6PC mutation, which was homozygous. Now in this case we took a decision, and they were also not affording to do in parents, whether it is a de novo or not. So then they told us that just do in amniotic fluid, this there is no need of doing in the parent, but then it is required to do in the parent. Here is another situation which I want to tell you, that the baby, the couple came, actually they had gone to ART specialist because the earlier baby died, and they knew it in 3 years. It was, there was a very severe congenital anomaly, severe spasticity, microcephaly, etc. They had done gone to the main tertiary hospital, but the confirmed diagnosis was not there. So we got all files. ART specialists had sent us here. We explained to them what is it and all, what are the conditions, which can be. And now we do not have any clue. We do not even have a blood sample of it. Now doing whole clean exam for them, that's what we tried, based on the clinical features, which are the features which could be there. And fortunately, unfortunately, both of them had certain common mutations which was probably occurring in that baby. That's what we just thought. We explain everything to them, the limitation of the thing. And then we saw that the doc7 and osap gene are similar to the variant which the baby had, those similar features. And in their next pregnancy we did this only two gene mutation. We ruled out that, continued the pregnancy, and they have now the normal baby as a female. Okay, so at times there will not be anything, you have to guess, you have to clinically correlate even in the dead baby. So getting the information from the earlier hospitals, earlier data files becomes very, very important. At times you have to talk to them also. But here it was is another case where the baby is there, but they approach at the late pregnancy, and no index case diagnosis was there. It was a very gross mental motor developmental delay, and the young couple. And when they come at 16 weeks of gestation, we know it takes 1 month. Again, even in the parents, if you do, it will be there. But somehow the other, the family was very anxious. They were ready to. The boy was the IT fellow, but when we found out both of them, they were carrying the heterozygous mutation deleterious, and which we found in this pregnancy quickly. What we did a simultaneously in parents also and the amniotic fluid, and which we found it positive. And therefore then we did the counseling, which becomes very, very important, because this was adreno leukodystrophy which we found in this case. And we counseled them that this baby is most likely going to be the same thing. It was a young couple. He was going IT fellow to Switzerland for a job. He took a decision. I told them that you are young, you can have a second baby again, carry all these things abroad, even if she is pregnant. And that was a decision they had taken it, even against the other family members. And you won't believe that sometimes the family members in Indian scenario, you will find that yes, whatever the baby is there, we will take care of it, even if it is disabled. So there, this time, I really found that young couple taking a decision against the other family members and discontinued the pregnancy. Here is a case where the lady comes who is a pregnant. You can see it here in the end here. And again, she gives me the family history of the hereditary multiple osteochondromas, which is very, very obvious. She has seen in her brother, she has seen in the other generation also earlier as such. And then at that time, instead of doing the whole clean exome sequencing or the specific one, we had to explain her what is the cause, what are the other possibilities are there. And these are the clinical manifestation was very obvious. Multiple osteochondromas in her brother onset was 12 years of age. there could be skeletal growth, bony deformity, etc. And in that time, you have to counsel them properly and say, okay, we are doing this test, we know these are the ext1 2 gene. You have to explain them in their language also, and then do the test, which we had done in this case again, because she was very very conscious about it. She was well informed educated teacher who wanted to see that I would not like to have a similar defect or a similar type of the disorder to my child or in my family to be continued. Now at times the such couples are going to come to you when they had seen, because it is now the Google era, the people will be going and finding out on the Google, and they will come with the something previous knowledge about it. Autism, as we know, is a very, very now becoming 1 in 64 by the US, and there it is a heterogeneous neurodevelopmental disorder, and number of causes are there. Number of sometimes the genes are also correlated. So at times, this if such baby is there, you can first do as a microarray, because there are the groups of the relevant aberrations related to autism have been they are shown on the OMIM thing. Here is the case which I saw you, which I showed you first in the family where there are two sibs are there. Now, more than that, though there was a boy and a girl, still the family was interested to go ahead and have a baby. Though the mother was, I had done the counseling with both mother and family separately. She didn't want to have a child. So at times the genetic counselor's role becomes very, very important. She had a pressure from family to go ahead for the new pregnancy, next pregnancy, get a normal healthy baby. And when we found out, we knew it is a beta lipoproteinemia case. And since we knew clinically very strongly correlated, also biochemically and histologically, fatty liver changes, liver biopsy was confirmed. And then when we found it, the genes also MTTP. What we did here is, when we saw in one of the index case we did for making it cost effective, and then we said this is the only possibility, we do not know whether it is the exact thing of it. But then she had come again pregnant, we had done amnio specific, the mutation for it, which was negative, it was heterozygous, not negative, it was heterozygous. And though in both of them, husband and wife, we had not done the carrier testing, but thinking that it is a heterozygous splice mutation, the clinician said he took a decision that it will be like a mother and a father and not affected and just the carrier. So the pregnancy was continued as such in this case. Here is a case where what why I wanted to show you is at times how the clinician and the scientist can do take a very good decision, have a very good interaction on the baby, on even the baby who has not survived here few days, but it was ARC syndrome. It is called as arthrogryposis renal dysfunction cholestasis. So based on the ultrasonography clinical, the clinician was very very strong about it. And because of the cost factor, the couple they do not want to do on them, because that was again a cost in our country is there. And what we did it, we know that it is mainly the common mutation is this VPS 33B. And when she came as a next pregnancy also, she had not done. But and unfortunately we got the amnio homozygous possible, and vivo use though it was, but still then we did the proper counseling and told them that it could be again a defective. And anyway, though they had not continued the pregnancy, ultrastructure sonography was done, and sonography also confirmed that it is a similar condition, and so they opted for to MTP2. So at times you will be coming across such situation where there are baby index cases there, or index case died, or you do not have the index case, you just have a clinical thing. So knowledge of a genetic counselor and counseling becomes very very important. The last is the advances in the NIPS. You have seen it as of in fetal diagnosis. The non-invasive prenatal test has come. It is nothing but some cell-free fetal DNA, which is a small fragment floating in the mother's blood, and which is there from the placenta secreted. But it is in a very, very small quantity in first trimester, increases with the throughout the pregnancy. However, this has been used as for the aneuploidy, and now also people are extending, and apart from the five common aneuploidy like 21, 18, 13, X and Y, they have also extended it to other chromosome. But remember, this doesn't give you any clue about any other structural abnormalities, or it doesn't give a clue up to any other translocation is there or a mosaicism. So I just wanted to share this case with you where the couple had come. They had one normal girl. Next time pregnancy also very late she came, and the ultrasonography was normal. Second trimester maternal screening, they showed the intermediate 21 trisomy 21 risk. But NIPS test did not show the 21 trisomy, but it showed the suspected chromosome 13 aneuploidy. So see here, we were in dilemma. Quickly the fish was done because they wanted to continue the pregnancy. Now that time, pregnancy time, they had the chromosome 13 three copies, but very, very low. There was a low grade mosaicism, 5% of chromosome 13. We continued side by side chromosomal karyotyping also, because you have to do that. The quick decision you give, do the fish. And then there was no structural anomaly, and the karyotype report was that time on of amniotic fluid was normal, no teeth, trisomy 13 mosaicism. Now what is the chance, how would you do? And here, in our scenario they will always ask the guarantee, you tell us definitely 100%. Okay, so at times then you have to take the support of the literature where you are, and then there are literature where we found that if it is a less than 10% of mosaicism, very low mosaicism, the outcome is good and you can continue the pregnancy. So this is the thing which you can convince, but again the decision is of them. And in the decision is of the parents, because in this medical legal era, you cannot take such risk, because there are people who will come back and tell you, "Okay, you are the one who told us to continue the pregnancy." Okay. And the last is the ART babies who are coming. It was a very good clinician who, just because of the neck, the very chubby, nice baby, normal development, but because of this, she referred it to us. It was out of ART baby was there, and query Turner syndrome, and we had here triple X
80%.
60% as such. Now, in this case, this is an error during non-disjunction or embryonic development, but genetic counseling has to be very, very carefully done. Has to be done. Triple case to both parents. You have to explain. Even the baby going to the school, teacher, remedial therapy, everything you have to do it. And in the next pregnancy, you may have to do the prenatal diagnosis of triple X women. So genetic counseling is the integral part of prenatal diagnosis, whether it's a pre-test, post-test in prenatal, whether it's invasive or non-invasive. So limitation of genetic test, timing of genetic counseling, informed consent, which you have to take it also from the couple. You have to know the PCP&DT Act in our country, which is there, that you have to, and whether when you are doing such genomic test, if you are not the laboratory scientist or the geneticist and having the knowledge of clinical geneticists, you see the lab accreditation and have the interaction with the scientists also on the other side. So prenatal genomic diagnosis is, in the end, if you see carefully, it is a multidisciplinary scientific approach. Along with the family thing, you have to have a reproductive specialist to do the procedure. You have to have a good radiologist or a fetal specialist to accurately do. You have to have a good laboratory scientist around you, interpretation and the bioinformatics. Call them, ask them. Sometimes, now recently just I came across some syndrome Gilbert, where it is supposed it's a geneticist or the genomic specialist who will know that when it is there near the promoter region, sometimes you do not see the repeats, you do not see the exam, the ending. So you have to have a discussion with them. You have to see that you do another test, you do Sanger sequencing and confirm, because it is the question of a life and death, because of the further future pregnancy. Okay, because the which test to be opted, generally clinicians will not know. It is a dilemma for them. Therefore, it is a teamwork of complete genetic evaluation before conception is ideal, but in our cases it doesn't happen. Now the couples are coming, as I showed you, but sometimes they are late in pregnancy. Okay, people are not well versed with the clinician about DNA diagnostic test, and as I told you, the contribution of geneticists, DNA experts, is becomes very, very important while advising them about the prenatal thing. At times, the clinician, they do cost affordability is a thing issue, and then they think from that point of view. But it is the genetic counselor who finally convinces them. Is it okay with it is this cost, you will find it just now, but it is a lifetime thing which you will be solving it for your family in index case. Okay, so it is a challenge in genomic era, and in a various situation there will be the prenatal diagnosis like syndromes, inherited medical condition, anomalies, birth defects, developmental disabilities, autism, or in the reproductive history bad. And on that side you will sometimes the consanguinity, advanced maternal age also with the NIPS coming, endocrine neurological cases and neuromuscular are maximum. If I tell you the 30% of our genes are expressed in brain, so number of genetic disorders are the neurological one. Okay, so prevention is certainly possible, but if the knowledge and experience of genetic science, prenatal genomic diagnosis is available, with that need, when we had felt it, me with Dr. Dhanlakshmi Shetty in 2022, we came out with this book, Genetic Counseling, Clinical and Laboratory Approach, covering almost all of the things in the chapter, those who are interested in this. And in the end, I would like to say India has got a huge challenge with our population. Every sixth child in globally is Indian. And with our cultural practices, norms, with the traditions, and even misconception, we have a huge genetic diversity here, multicultural, varied religious and ethnic background. So one has to keep his eyes open when the cases come to you. They are from which area, geographical area, or their religious. You will find in Muslims and other thing quite a number of consanguineous marriages and the repeat of the MR cases, but that is not always the case. So that knowledge becomes also very important. And the whole genome mapping, where we find it, even if it is a VUS, at times we have to consider it, because it could be the first time in our population coming as such. So, with that, I will end it saying that it is a need of today to reduce national burden. And we know theory behind human genome and the DNA, but translate it into practice and give benefit to the patient, that requires special awareness. That's a Charles Cliver, very favorite of mine, and I like to quote by ending it. Thank you so much.
Thank you, ma'am, for such an excellent, comprehensive, and holistic approach that you have taken for, going through this entire genetic counseling in the prenatal genomic diagnosis. We thank you so much for joining and giving us this enlightened talk. And You have also explained the role, the importance of the genetic person, the lab scientist, uh, the clinician here, and as well as the genetic counselor. So this is basically the scope or aim of GCCI, and we would request you, or would want to invite you to join us in this group to give us some further knowledge and how we should grow further. And we will also request the others who are interested in this consortium to join us. Thank you so much, ma'am. We would be
Thank
looking
you.
forward for your guidance in future as well.
Thank you so much. I'm always there, Dr. Nallakshmi and Dr. Niyaz, all of you GCCI team, anytime, any assistance, help you need, I'm always there. Thank you.
Thank you so much, ma'am. And we would conclude, and we will, in future, the talks and all will be shared again. Thank
Yeah,
you so much, ma'am. Thank you
thank
so much for your time. Yes.
thank you. Thank you.
Have a
Bye.
Thank you,
nice day.
ma'am.
Yeah.
Thank
Thank
you
you.
very much, ma'am.
Thank you, Dr. Niyaz.
Ma'am, if you have 2 minutes, I just wanted to know
Yes, yes.
some. Yeah, yeah, ma'am. The services that you're providing at MILS International, as well as
Nebijin Genetic Lab, yeah.
Navy Gene Genetic
Genetic
Lab,
Science Lab.
because most of the audience probably they don't know, and we didn't discuss so far. Just highlight couple of services that you're giving, because that what matters to us
Yeah,
also. If you can connect someone who is really into in the need.
yeah, sure. See, the Males International India is actually when I started, I was the first one to start in India. GCMS analysis from urine. Professor Matsumoto in Japan is the pioneer, and now he's no more, but he is my mentor. and guide. And that's how we started in 98, 2000. There was nothing in AIMS or nowhere in India. I used to get the sample from all over. So that's how we started metabolic genetic profiling by gas chromatography. Now there are TMS and GCMS which are there. So with that, we had just started at the services, and now we have the labs here. We have a genetic laboratory recognized. We get the patients also. We do the telemedicine counseling also. Then after that, the samples do come here. Even after diagnosis, we do both newborn screening. We do metabolic screening by TMS, GCMS, genetic diagnosis, further confirmation of it. Prenatal diagnosis, as I told you, these are the couples who come. They are referred by the doctor, and then there is always the exchange going on, and we give the guidance to that current obstet gynac, because they are the one who are going to take care of that pregnancy later on. So that sort of genetic counseling we do. And Navigin Genetic Science Lab is also the similar one, where I got the opportunity to establish and expand more. So I'm as a laboratory director, medical geneticist working there, and giving my whole consultancy services, guidance. And it's a research lab. What I have maintained is the academic research. Okay, so I'm still a
Yes, ma'am.
and yeah, so that is the opportunity which Navigin Genetic Science Lab has given me. And I continue my academic and other educational training activities. I just I'm a vice president of Molecular Pathology Association, founder member of ISIEM, that is Inborn Era Metabolism Society, and the ISPAT, Indian Society for Prenatal Diagnosis and Therapy. I was a president for 2 years.
Yes, ma'am. So what I'm thinking, ma'am, because this is an initiative from both the organization, Bioclues and
Yes,
Bioservices. This is not for profit
yes,
organization,
yes,
both the
right,
organization.
right.
So we are little inclined towards lot of academic activities,
Yes,
in near future also, and we have done
sure,
so far.
sure.
So, ma'am, what we can do, because a lot of young professionals,
Yes,
those who are from genetics background, masters or genetic counseling background at
yes,
level one, two, three,
right.
they need some sort of hands-on training
Yeah,
in this higher end test. That is,
yeah,
Coming.
we are doing it, and you're also mentoring it, like for a long time
right.
now.
Yeah,
And so let's see how we can work together
sure.
and move
Yeah,
further, because you have a great facility over there, and under
yeah.
your leadership, probably we can design some module
Yeah, we can
for
module
a
genetic
very,
counselor courses, we can
yes,
design.
I
Maybe
mean,
we can put them in different
Meeting
laboratory
is
for
still
some
going on.
time, and we can plan that sort of course. Of
yes,
course,
or maybe
definitely.
we can have a like
Huh?
very affordable,
Yeah,
No, no,
package
no. I
for
have to
training
end now.
yes,
services, as
So,
well as
yes.
some
which is
diploma or
fine.
degree courses,
Yeah, there are sometimes online also,
Yeah,
Asia
yeah, yeah,
Please
right.
and other interline, they are very interested in
I'm,
online
yeah,
also, we
yeah.
can.
Yeah.
And we can start connecting with different labs, those who are interested for practicals. We
Yes.
can put them in a different lab, 2 3 labs also, and give them hands-on training.
Yeah.
We can do some structuring of some such type
Yes.
of
I mean, we are
activity.
lucky that we have a like senior genetic counselors with us, Dr. Dhanlakshmi,
Yeah,
and we
she
are like
has also good
common
lab.
friends. Yeah.
Yeah.
You can say like common resource person rather.
Yes, yes, sure,
You are very
sure,
senior to us, so with that regard, actually.
sure.
So let's see, we can connect,
Yes,
sometimes later, and we can discuss what we can do
yeah,
together. Thank you
sure,
so much,
sure.
ma'am, for your time once again, ma'am. Thank you so much.
Thank you, thank you. Thank you so
Yeah,
much, and all the
Thank you,
best.
ma'am.
yeah,
Once.
thank you.
Thank you. All the best.
Sunil, would you like to share some of your
Yeah,
experience
yeah,
being a chair
yeah,
of GCCI?
yeah. Yes, yes, sure. Uh, Ma'am, this is Sunil from Loknaik Hospital. So I
Yes,
am very happy to be part of the team. Dr. Niaz, Dr. Dhanlakshmi, and Prashant has initiated this GCCI part, and we are very happy that uh, you being a uh, expert in the neuroscience as a neuroscientist and medical geneticist for the past 30 years. We are very happy that you given a enlightenment to a very great enlightenment to us by sharing your experience you have done the GCMS first time from India.
Yeah.
Sir, that is very because we
Started.
are also doing GCMS here. After your experiences only, we have started in Delhi,
Okay.
Lobnaik Hospital,
So
Dr. Sima
Maulana
Kapoor.
Azad.
Yes, ma'am. Yes, ma'am.
Yeah, yeah. Sima Kapoor.
Dr.
Okay.
Sima Kapoor.
Hmm.
So I am working with Dr. Sima Kapoor for the past 14 years.
Oh,
So I
okay.
am looking after the newborn screening part and genetics.
Okay.
We are
Very,
looking up
very
single
good.
gene disorders also, like thalassemia and hemoglobinopathies. We are doing, and for the students, we can make some brief.
Yeah, there is a need. We can do some training, hands-on training together. Sure.
Actually, we are not able to provide the counseling, ma'am, because
Mm-hmm.
MSc people are coming, but they don't know about the basic concepts of genetic counseling. So
Right,
how to explain to the parents because
right.
sequencing part is there. So how to explain the
I have to
sequencing
go.
part because they
See,
don't know what
this
is
is late.
sequencing. So
Correct. Right.
that things should come into a layman language so that they can understand the things.
Okay,
And
I'll
for
take it from you.
karyotyping also like that only, ma'am. So how
Sure.
to
I
Yes.
have to
so Down
pee.
syndrome baby is there. So we are saying that आपका बेबी को प्रॉब्लम है तो मानसिक
Yeah.
बुद्धि हो
Correct.
जाएगा करके बता रहे बट we
Yeah.
are not able to explain them properly. We can provide the booklets like that, yeah, pamphlets type,
Yeah.
so that easy language they can
We're
understand and they
discussing
can do.
something, right?
So this is
Correct.
what we want to
Medium
implement.
stove.
So
You know,
Niaz is already
And
doing.
even
what's
clinicians
the
also,
timing
the
they
young
gave?
MBBS
7:30 to 8:30.
doctors or something,
But
then 2002, it
it's
was not
already
there in their
8:44.
curriculum.
No,
Okay.
now they have
Yeah. So
started the
now they
curriculum, ma'am.
have, yeah, I believe. Now they
But actually they are coming for, as an elective only.
have.
Only for
Dinner
one
time is
month they are coming to us.
check.
They are
Okay.
just observing the techniques and they are going. They are not attending the patients. So
No, no.
how they
Genetic
can learn the gen-.
counseling is a separate thing, which under
Yes,
which there will be biochemical genetics,
yes,
cytogenetic, and
genetic and
molecular
molecular
genetics.
genetic. Yes, ma'am.
Okay, because
Uh,
just last week only I had this case with clinician is so insisting that no clean exam, whole exam sequencing means all genes are covered. See,
yes,
company
ma'am.
people go and they tell them all genes are covered in this. Okay, so you can do this one test. Array, but the baby neonatal was the myotonic dystrophy, or they are suspecting the muscular dystrophy, or whatever SMA thing. And now
Uh,
these are sometimes a repeat disorder. You have to understand the technology. There is no need for clean exome first. You have to do this. So
yes,
finally, I do not know. Again, when we convened them, then he came back and said, "Yes, yes, madam, I
uh,
agree."
yes, ma'am. Here also the same thing occurs because
So it
they are
happens.
sending Fragile X cases directly for
Mm.
karyotyping. We say that karyotyping we will get the normal report, but you have to go
Yes,
for
yes.
CGG repeats.
Correct. Yeah.
That we are explaining to the patients.
Yeah, and there was a time when folic acid deficient medium करो ये करो हम लोगों ने वो भी किया है. Then you see the even
Introjection.
Dhanlakshmi Asin, we had seen a fragile chromosome very nicely in fragile X syndrome. But
Okay.
that time there was no FMR1 mutation, mutational study
Yes,
नहीं
ma'am.
थे, and
Uh,
not that always you will see. No, it's 15 to 20% you will see
oh,
in
yes, ma'am.
type. So all these things we have gone through, and now come to the this latest technology.
Uh,
So which one to choose is very, very important,
yes,
crucial.
ma'am. Yes,
Looking at
Yes, in cytogenetics, we have got many
yes,
cases, Fragile X, but then you know how tedious it is to do 100, 200
yeah,
metaphases and look at the
yes,
fragile site and all. It's very tedious and we may miss out things. And
yes,
at the end, it is the CGG repeats that we need to report, right? So,
yes,
which cannot be
right,
done by karyotyping anyways.
yeah,
So, yeah.
now NIPS is also like that only, ma'am, because they are
yes.
routing NIPS, but sometimes the reports are coming abnormal reports, and the patient is going for MPT
No,
sometimes.
no. After NIPS, they shouldn't.
They
After
sh-
NIPS, first pre-test counseling only you have to tell
ah,
them
yes, ma'am.
that
That is what
uh, pre-test counseling, you have to tell them that after NIPS positive, you have to do the invasive
invasive
chromosomal
procedure. Yes,
karyotype
ma'am.
test.
Yeah.
Then only there is a point of going ahead.
Ah.
On basis of NIPS, you cannot take just
We
okay.
explain
Down
that one.
syndrome is straight away and ultrasonography fetal anomaly is confirming the features. Then it is okay, and then they
Yeah.
have taken. So one was a nurse who opted
Oh
for
my
that.
God.
She was a medical nurse. She had seen fetal anomaly scan Down syndrome properly. NIPS positive आया, तो she took the option because it is a cause. She said मुझे मालूम ही है मैं क्यों अभी amnio करूँ, cardio करूँ और ये करूँ. So see the decision changes from individual to individual.
Details. Because now advanced age only they are doing most of the
Yeah.
cases. What we are getting is 40 plus cases also they are
Hmm.
going for NIPS.
But it is not always advanced. See, the Lakshmi will agree with us. We had conducted a study. 80% of women of having Down syndrome child, they are below 20 years of age. Between 25 and 18 years of age they were. So our scenario, this has come from abroad. Okay, advanced age
Yes,
thing. Now in our culture, they are getting married early. They are having children early. So there could be Down syndrome because what even we have
folate.
found in NIPS, yeah, younger women also.
And due
So
to folate deficiency, maybe.
yeah, and that's why they are saying ki routinely also you can do in all high risk
Yes.
pregnancy cases.
Yeah. This is what we have
And
to.
SCMG guideline is saying that routinely in all pregnancies you do NIPS.
Okay.
Though in our scenario we cannot afford yet.
Yes. So these all things we can make a schedule type and we can
We
plan.
can design proper program and
Yes.
then we can go ahead.
Sure. Thank you very much, ma'am.
Thank you.
Thank you.
Thank you so much. Okay. Thank you, everybody. Good night.
Good night, ma'am.